Hello and welcome to a discussion on the histology of the urinary system. So the urinary system is going to be composed of the kidneys, the ureters, the bladder, and the urethra. Right. Function-wise, the kidneys are going to be involved in excretion of metabolic waste. And you're going to talk about secretion, filtration, reabsorption in your renal physiology. You're also going to talk about the endocrine function of the kidney, where you're going to produce renin. They also help in the conversion of your vitamin D, which is a prohormone, into 1,2,5 hydroxyvitamin D3. They're also going to secrete 85% of the erythropoietin, which you need for normal erythropoiesis in the bone marrow. They're also going to secrete about 15% of the thrombopoietin, which you need for the production of thrombocytes, which are essentially going to be our platelets, right? Then if you look at the kidney, the smallest functional unit of the kidney is going to be the nephron, right? And the nephron will be composed of a renal corpuscle, which leads to the PCT, which is our proximal convoluted tubule, where we're going to have an abrupt change in the epithelium from a simple squamous epithelium, the one that we expect in the renal corpuscle, to a simple cuboidal epithelium in the PCT, our proximal convoluted tubule. Then from the proximal convoluted tubule, we lead straight to the loop of Henle. Then we get to the DCT, which is our distal convoluted tubule. When we get to the collecting system, when we get to the bladder, the ureter and the urethra, which I will describe in one go, right? But before we talk about all that, it is quite essential to remember the circulation within the kidney. So histologically, you divide the kidney into a cortex and a medulla. I'll show that on the pictures and the subsequent slide. But the cortex essentially will receive most of the blood in the kidney. It is well vascularized as compared to the medulla. And you'd remember from your gross anatomy of the abdomen, you're going to have renal arteries emerging at around L2, and they're going to be lateral visceral branches of the abdominal aorta. They'll not only supply the kidney, they'll also supply the suprarenal glands, the lower parts, of course. They also supply the ureter, right? These renal arteries would divide into about 10 segmental arteries, which are going to divide into interlobar arteries. Subsequent or adjacent interlobar arteries are going to be joined by an arcuate artery, which I'll show on the histological pictures. And from the arcuate arteries, you have interlobular arteries. The interlobular arteries are then going to irrigate the glomerulus, where you're going to have the capillary bed, which is the first one. Just like in the abdomen, where we talked about a portal circulation, where you're going to have absorption of nutrients at the capillary bed level, then transported by your hepatic portal vein towards the liver, then assimilated in a second capillary bed, making it a portal circulation because you're bypassing the heart and moving through two successive capillary beds. That's going to be the same case if you look at the hypothalamo-hypophyseal portal circulation between the hypothalamus and our pituitary gland. Basically, the adenohypophysis, which is our anterior pituitary gland. You also bypass the heart by moving through two successive capillary beds. And that's how you have the releasing hormones getting to the anterior pituitary gland before they are pumped to the rest of the body. That's going to be the third case for the kidney. You're also going to have a portal circulation. Why? Because if you look at the glomerulus, where we said you have the afferent arterial feeding, it's going to be drained by an arteriole, which is an efferent arteriole, which then irrigates a second capillary bed. For the purposes of the nephrons that are entirely in the cortex, which we're going to call the cortical nephrons, they irrigate what are known as peritubular capillaries. For those that are closer to the medulla or adjacent to the medulla, the juxtamedullary nephrons, which make up a seventh of the total nephrons in the kidney, they irrigate what are known as vasa recta, recta meaning straight vessel, right? So the dilated portion of our nephron, the upper part, is going to be the renal corpuscle, which consists of the glomerular capillaries that are going to be surrounded by a two-layered capsule. Our two-layered capsule, we have a parietal layer and a visceral layer. The parietal layer is going to be lined by simple squamous epithelium. Remember, initially when I started, I say that between the renal corpuscle and the PCT, there's going to be an abrupt change in epithelium from the simple squamous that I'm describing for the renal corpuscle to the simple cuboidal epithelium that we're going to mention with the PCT, right? So the outer parietal layer has that simple squamous epithelium. Then the inner visceral layer has what are known as podocytes, the stellate cells, right? The podocytes are going to give rise to what are known as primary processes. Primary in the sense that from the primary process, we image another process, which is going to be the secondary process. Our secondary process is the one that we're going to call the pedicels, right? And the space that lies adjacent or between two adjacent pedicels is going to be a slit pore. And those slit pores are bridged or covered by what are known as slit diaphragms. The slit diaphragms are made up of specialized tight junctions, which have the protein nephrin, right? So the slit diaphragms are made up of nephrins, which make up those specialized tight junctions. And the very important space that we're having between the outer parietal and the inner visceral layer, that's basically our urinary space, right? If you look at the renal corpuscle, it'll be wise to call it a polarized corpuscle. Why? Because we have a tubular pore where it joins the proximal convoluted tubule. Then we have a vascular pore where it's being irrigated by the arterioles. The afferent feeding it, and the efferent draining it. Funny enough, we have a capillary bed in this case, which is being fed by an arteriole and being drained by an arteriole, instead of being fed by an arteriole and being drained by a venule, right? Then from our renal corpuscle, we get to the proximal convoluted tubule. It's quite easy to describe the PCT with the DCT because they're almost similar, but there are differences, right? So the epithelium that we find in our proximal convoluted tubule is a simple cuboidal epithelium, which is also going to be the same epithelium that we're going to find in the distal convoluted tubule, the simple cuboidal. Look at them, they're highly tortuous, right? And they actually fill up most of the renal cortex in the kidney, right? The simple cuboidal cells within our PCT, they're going to have microvilli on the luminal side, basically the apical end of your PCT lumen. And under the light microscope, they appear or present with a brush border. And the microvilli in the PCT are different from those in our DCT in that they're going to be longer as compared to the DCT microvilli that are shorter, and there is no brush border in our distal convoluted tubule, right? If you also look at the cells in the PCT, they're quite larger than the cells in the DCT, meaning to say in a transverse section, if you look at the lumen of the PCT versus that of the DCT, which I'm going to show on the pictures, the PCT, you're going to find basically about 3 to 5 central nuclei on a histological cross-section. Unlike for the DCT where you have more. Why? Because the cells are going to be smaller. So you actually need more cells to make up the lumen right round, right? Then most of the reabsorption occurs within the PCT that you must have mentioned in your renal physiology. The ions, the sodium, the potassium, the glucose, and everything, right? And if you look at the cells, they have basal infoldings, that is in the PCT as well as in the DCT. And with the PCT, the cells appear highly acidophilic. Why? Because there's an abundance of mitochondria. It's one of the same concepts we used in JIT histology, when you say that apparatus cells, we're going to have abundant mitochondria, which are going to make them highly acidophilic under the light microscope. Right? If you look at those in the DCT, you have less mitochondria. Right? Then between the PCT and the DCT, you find the loop of Henle. The loop of Henle will have a thin descending, a thin ascending, and a thick ascending. The two thin parts are going to have simple squamous epithelium, whereas the thick ascending part will have a simple cuboidal epithelium as it becomes continuous with our DCT, right? And from your renal physiology, there's a countercurrent exchange mechanism that you described there. And one of the bases of that mechanism is that if you look at the thin descending part, it's going to be permeable to water. However, the thin ascending part is impermeable to water. You're simply going to have the sodium potassium 2-chloride transporter that is going to move the ions and not the water. So you're going to have sort of like an osmolarity gap between the two sides, right? That you talk about in your renal physiology, right? Then something that I could have mentioned with the renal corpuscle that I'm not mentioning now as a whole, there's something called the juxtaglomerular apparatus, which is going to have basically 3 cells making it up, right? There's the macular denser cells, which are columnar and basically closer to the DCT, and they sense the chemical nature of the urine, whether it's concentrated or it's more dilute, for you to change rather the renal filtration rate and the way you're actually filtering the urine, right? And the other cells, they are going to be the mesangial cells and the juxtaglomerular granular cells. What I would roll mostly on are the mesangial cells, right? Angio meaning vessel, mesos meaning in the midst of, right? So they're among the blood vessels. And to distinguish them from the podocytes is quite hard, but one of the distinguishing features there will be the fact that they stain darkly, right? And these mesangial cells, they resemble pericytes, which from our blood histology, or blood vessel histology, we say that capillaries are going to be 1 cell thick. And if they're going to be 1 cell thick, basically they're the endothelium, endothelial lining without a subendothelial layer. And they had no tunica media, no tunica adventitia. And they're going to have pericytes on the outside that are going to support them, right? So these mesangial cells, they resemble pericytes in the fact that they're going to be contractile, just like our pericytes in the capillaries. And our pericytes also had a stem cell function, which I'm not really going to ascribe to these mesangial cells. The other functions include protection and support of the arterioles and the capillary bed. They also help in phagocytosis, which is phagocytosis of adherent material in the glomerulus. They also have a contractile function, like I said, and they have an immunological function in the secretion of cytokines, right? Then if you look at the collecting system, you have 2 types of cells. They're going to be the principal cells, which are the most abundant, and those cells are going to be columnar to cuboidal. Then you have what are known as intercalated cells. There's the type A and the type B cells. Type A cells basically help regulate acidosis or acidic environments, and they help in exchanging H+ ions for potassium ions from your renal physiology. Then the type B cells basically help in bicarbonate regulation, basically the basic side of things, right? And they exchange that for chloride ions, right? When you get to the ureter, the bladder, and the urethra, all 3, they're going to have transitional epithelium or urothelium, with the exception of the distal parts of the urethra, right? If you look at the prostatic urethra in the case of a male, it's going to have this urothelium, our transitional epithelium. Then if you look at the membranous and the penile, they have stratified columnar and pseudostratified. But the distal part of the penile urethra or spongy urethra is also going to have an extra stratified squamous. Remember it from the embryology. It's the one that actually comes from the surface ectoderm, right? And in terms of the muscle, remember the muscularis of the ureter is quite thick, and the bladder has three muscle layers which are poorly delineated, the ones that we call the detrusor muscle, which are clearly seen when you get to the neck of the bladder when they become continuous with the muscle layers of the prostate, right? And to describe our transitional epithelium, you're going to mention how you have three layers. So there's the basal layer, then you have the middle layer, which has about 3 to 5 cell layers, right, that are more or less columnar. Then you have the superficial cells that have a bulbous or umbrella shape, right? Those superficial cells that have that bulbous or umbrella shape, they're going to be flat when the bladder is distended or when it's actually full. And when it's empty, they're going to be umbrella shaped or bulbous, right? And in terms of the nuclei, in transection, they actually appear bi or multinucleated, right? Then this right here is a slice of kidney tissue, right? And it simply helps us to appreciate the cortex, which is this one, right? Then that's the medulla right there, right? To look at the medulla itself, it's going to have an outer medulla here. Then there is the inner medulla right there, right? Then you can see a blood vessel right there that is forming an arc, as an arcuate arteriole, or an arcuate artery, whichever way you may want to call it. Right. Then also from this picture, we can see the presence of a papilla here. That's a renal papilla, right? Then these here, those are our interlobular vessels. These ones that are coming from the arcuate vessel there, those are the interlobular vessels. So this piece of tissue simply helps us appreciate cortex and the medulla, right? That's normal kidney tissue. If you then look at a slice of the histological tissue now, right? That's histological tissue, right? And on the outside here, this here is cortex. That's cortical tissue. This here, this is medullary tissue now. Right? In these regions here, these are renal corpuscles. So all these are renal corpuscles here. So those are renal corpuscles within our cortex, right? And these are blood vessels. So that's a blood vessel, that's a blood vessel. The smaller ones here, between the medulla and the cortex, those are going to be our arcuate arteries here, the smaller ones. And these larger ones, they're going to be the larger blood vessels, right? You can also appreciate it here. Those are blood vessels. The smaller ones on the sum of circumference, those are going to be our arcuate vessels there, right? Right. Then from this high magnification, probably times 25, that's a renal corpuscle, that's a renal corpuscle, that's a renal corpuscle, that's a renal corpuscle, renal corpuscle, renal corpuscle, renal corpuscle there, right? Then in between here, these are what we call medullary rays, right? So those are our medullary rays here. Those are medullary rays, right? Then that's a higher magnification. Those are tubes. I'll show you in the next slide how to differentiate the PCT from the DCT. Those are corpuscles on the other end there. That's a corpuscle here. That's a classic corpuscle. All these are tubes, right? You'll be able to distinguish now the DCT from the PCT using the description that we're just having. If you look at the DCT, they have more cells making up the lumen. They have an empty lumen as compared to the cells that are on the my far left, right? Then if you look at this one, right, that's a high magnification now, where we can now clearly distinguish the DCT from our PCT. For example, this here, this is a proximal convoluted tubule. We can see a brush border right on the inside there, and that lumen doesn't appear empty. This here, that's a DCT. We can appreciate that the lumen is empty, right? If you look at the lower inset, that's a renal corpuscle, right? That's a renal corpuscle. This here is our DCT. Look at the empty lumen. Look at the one that is just adjacent to it. That is a PCT. The lumen is not empty. You can see the striated border, right? That on the other end, then remember I said it is an arterial pore and a tubular pore. This is the tubular pore. Right here we have an arterial there. You can even look at the layers of the blood vessel. Remember how as you go to the lower vessels, the media, the adventitia, and the intima, they actually sort of become smaller, right? That right there is our Bowman's capsule. Right? That's the urinary space, the widest space there. Right. If you look at this inset on my left, those right there, those are podocytes. Right? That's a podocyte. If you look at this one, more cells and transverse section, that's a distal convoluted tubule. Adjacent to it, less cells, we can see 3 to 5 nuclei, and lumen that is not empty, striations, meaning that's a PCT, right? Then this one, maybe what I would want you to see here now is the presence of this structure here. That's a collecting duct. The cells are cuboidal, right? And remember we said you find principal cells and the intercalated cells there, right? This is a classic picture. That's a blood vessel there, right? Then on your far left, in this corner here, those are renal corpuscles there. This is a pyramid, right? That's a pyramid there. And we can appreciate transitional epithelium here, right? That's transitional epithelium right there, right? Then on the other end, this looks simple. It's not stratified, right? That's simple columnar epithelium right there, right? Then this one is classic picture of the ureter, right? If you look at that as a full cross section, it's going to appear with a lumen that is starry or star-shaped, whichever way you may want to call it, right? That's the mucosa right over there. That's the epithelium, right? No need to be told what type of epithelium it is. That's transitional or urothelium, right? Then mucosa, you remember it as the epithelial lining. Then below the epithelium, you expect loose connective tissue for vascularity of the epithelium or provision of the nutrients, right? And that's going to be the loose connective tissue just below the epithelium there, right? Then this is smooth muscle here. Remember the smooth muscle in the ureter is quite thick. There's a smooth muscle, right? There's a longitude now, right? Then there's a circular on the outside there, right? Then all these are blood vessels, right? Those are blood vessels. On the outside here where we have fat, that's the adventitia, right? Quite easy to remember. That's high magnification, still our urothelium, which I said is 3 layers, the basal layer there. Then that's the middle layer, just 3 to 5 cells, layers that are going to be columnar. And the bulbous cells there, those are simply our superficial umbrella cells, right? Then from this, we can also appreciate a bit of connective tissue or lamina propria. We can also appreciate a bit of smooth muscle. This is the longitudinal smooth muscle. Right? There's a bit of a reverse of what you guys would have been used to. You started with JIT histology, where you usually say outer longitudinal and inner circular. In this case, there is outer circular and inner longitudinal, with the exception, of course, for the lower ureter, where you add another longitudinal layer, and that's going to be the case in the bladder. However, in the bladder, remember I said the epithelial cells are going to be poorly, the muscle cells rather are going to be poorly delineated. Right, that's a classic picture of the bladder, histology of the bladder. Right, right. On this side here, that's epithelium. That's all epithelium. Right. On this side here, that's a ureter. Right? That's a ureter right over there. Can you see the epithelium is almost the same? That's urothelium. Right. And you can appreciate blood vessels. That's a blood vessel. That's a blood vessel. There's a bit of fat. Right. Then you can look at the muscularis layer here. Right. Quite prominent. That's the muscularis layer that detrudes the muscle. But they're poorly delineated. You can't really tell which one is the circular, which one is the longitudinal, with the exception, of course, when you get to the neck of the bladder, where it becomes continuous with the muscle layers of the prostate. Right. This is still bladder. That's simply showing us the same urothelium that I've been showing. Right? That's urothelium right over there. Below the epithelium, that's a bit of connective tissue, which is going to be our loose connective tissue. Right. Then this is smooth muscle. Right. We can see smooth muscle right over there. Right. And we can see a bit of lymphoid tissue there. Right. That's lymphoid tissue. Right. If you look at this end, that's smooth muscle again. Right. Then you have a bit of connective tissue high up there. That's connective tissue. Right. So that's just about it.